Hello everybody, welcome to Brainy Dental. In this video, I have described stepwise management of deep carious lesion. This is the order a student should follow while answering a question in the exams. And the same order should be followed in the clinics while handling a patient. So let's go ahead and watch. There are 4 steps in the management of deep carious lesions. The first step is to take the periapical radiograph to assess the depth of the lesion, how close it is to the pulp. The second step is cavity preparation. The third step is to assess the remaining dentine thickness after the cavity preparation is over. And the fourth step is the restoration. Now, depending upon the thickness of the remaining dentine, we decide whether we have to do a simple restoration, perform indirect pulp capping, or perform direct pulp capping. Now, we will do all the 4 steps in details. Periapical radiographs are important because they help us to assess the extent of the carious lesion. Now, 3 situations can arise. The first one is that the lesion is approaching or exposing the pulp. Now, if you look at the radiograph, you will observe if this is the outline of the pulp here, then this is the outline of the lesion. So, the lesion is in contact with the pulp. So, how will we manage this situation? We will go in for a root canal treatment. Now, the second situation is that the lesion is close to the pulp. Now, if you observe this radiograph, this is the outline of the pulp and this is the outline of the lesion. So, it is close to the pulp, but it has not approached the pulp. Here, you can manage it by the procedures of indirect pulp capping or direct pulp capping. Now, the third situation that will arise is that the lesion is safe distance away from the pulp. Now, you look at the same radiograph. If this is the outline of the pulp, and this is the lesion, it is safe distance away from the pulp. Here you can do a normal restoration in which you can give a base and then followed by a metallic restoration or some other permanent restoration. Our next step is to cavity preparation. How do we go about it? The first thing we do is we isolate the tooth with help of a rubber dam. Then, using a large round burr on slow speed, look at the diagram, we penetrate the cavity, and after penetration we excavate the cavity with help of a spoon excavator. And we use the spoon excavator in form of gentle featherweight strokes to remove soft wet carious dentine. So of all the soft dentine, we try and remove it. And what do we leave behind? We leave behind dry, fibrous, demineralized dentine. Now, this dentine is relatively hard and it offers some resistance to the scraping motion with the spoon excavator. So, we come to know that this leathery kind of dentine we should leave behind. Now, after that, we carefully check the cavity walls for any residual caries. Now, in case there is any caries present on the walls, we remove it. After the cavity preparation, we assess the remaining dentine thickness. Now, in this first situation, you can observe this is the cavity preparation and this is the floor of the cavity and here is the pulp. So, the distance between the floor and the pulp is greater than 2 mm. So, that means we have a sufficient bulk present between the pulp and the metallic restoration or any permanent restoration that we need to give. So how can we restore this particular tooth? Now, in case we want to give an amalgam restoration, we can apply a layer of base here or a layer of varnish and then we can restore it with amalgam. Or in case you want to go in for composite, you can directly go in for a composite restoration, or you can go in for a cast metal restoration or a ceramic restoration as you wish to. So this is how we can manage a tooth with sufficient dentine thickness. Now, in the second situation, if you observe the cavity preparation, you will see that this cavity preparation on excavation has come very close to the pulp. You can see it. Now, here you can observe that the remaining dentine thickness, like this, it is less than 1 mm or say 1 mm. It is pretty less. Now, in this kind of situation, what happens is that there can be microscopic pulpal exposures which are not visible to the naked eye. And these exposures, they are large enough to allow direct access to the bacteria and the fluids. So it becomes here like this to the pulp and it can cause an exposure. So what do we do? In this case, we will perform the procedure of indirect pulp capping. In the third situation, you can observe that during cavity preparation, there was an accidental exposure of the pulp that we can see with our naked eyes. Now in this situation, when there is directly exposure of the pulp, what we do is we go in for a procedure called as direct pulp capping. Now we will discuss both the procedures, indirect pulp capping and direct pulp capping, in detail. Indirect pulp capping, it is a very important short note question from examination point of view, so you follow it carefully. First step is the definition. Now it is a procedure where the deepest layer of the carious dentine, that means this particular layer, if you look at this diagram, is left behind intentionally, covered with a biocompatible material in order to prevent pulpal exposure and further trauma to the pulp. Coming to criteria, that means which tooth can be considered for pulp capping. Now the tooth has a deep carious lesion, and after that lesion there is no history of spontaneous pulpal pain. Then the pulp is vital, as confirmed by thermal and electric pulp testing. And the pain arising from the pulp testing does not linger after removing the stimulus. Then periapical radiograph shows no evidence of periapical radiolucency. So this tooth can be considered for pulp capping procedure. So we have a situation where we have the deepest layer of demineralized dentine, which is covered by calcium hydroxide liner or any other pulp capping material, and which is then further covered by a temporary restorative material. So this is the indirect pulp capping procedure we have done, and now we should know about the materials that we have used. Pulp capping material is basically used which causes the regeneration of reparative dentine, and popularly we use calcium hydroxide or mineral trioxide aggregate. Then the intermediate restorative material commonly used as zinc oxide eugenol cement and resin modified glass ionomer. Now you see this zinc oxide eugenol cement, it is special because it has sedative or palliative properties, and it helps to reduce the post-operative sensitivity of the tooth. The purpose of this procedure is regeneration of dentine forming calcific bridge. Now I want you to look at the diagram. You will observe this is the layer of calcium hydroxide which is overlying the decalcified dentine. Now alkaline nature of calcium hydroxide will ensure that it eliminates the bacteria present in this decalcified layer of dentine. And this overlying restoration which is present, what will it do? It will prevent any entry of new bacteria or bacterial products inside this lesion. So ultimately it will lead to the arrest of the carious lesion, and that is what we want to achieve. Now duration for which we keep is 6 to 8 weeks. What is the outcome after 6 to 8 weeks? The favorable outcome is that the tooth is vital. There are no symptoms of pain or sensitivity. At this stage, we then remove the zinc oxide eugenol filling. We check the calcium hydroxide layer. If we required, we redo it, else we let it stay the way it is. Then we place a layer of base over it, which is followed by a permanent restoration. So this is your procedure of indirect pulp capping. Direct pulp capping procedure. I want you to observe the diagram. You can see there is cavity preparation in which pulp has got accidentally exposed as a result of operative error or misjudgment of depth in case of a deep carious lesion. So how do we define it? It is a procedure in which the exposed vital pulp is covered with a protective dressing placed directly over the exposure in an attempt to preserve the pulp vitality. So let us see how we do it. What should be the criteria that would allow the direct pulp capping procedure to be a success? Firstly, the exposure formed should be small, that means less than 0.5 millimeter in diameter. Then the tooth which has got exposed, it should be asymptomatic, showing no signs of pulpitis. Then the hemorrhage from the exposure site should be easily controlled. That means if you take a moist cotton pellet and you apply pressure, you should be able to control the bleeding point. Finally, the invasion of the pulp chamber was relatively atraumatic with little physical irritation to the pulp. Now, what are the popular pulp capping materials that we use? Calcium hydroxide, mineral trioxide aggregate, tricalcium phosphate, or biodentine. Coming to the procedure, the first step is to isolate with rubber dam so that we can achieve a clean, uncontaminated operating field. Then we apply a lining of calcium hydroxide using a flow technique, that means without any pressure, to cover and protect the point of exposure and also extend over a major portion of the excavated dentine surface. I want you to look at the diagram. Now you can see there is calcium hydroxide applied right on the exposure side plus on most of the excavated surface. The purpose of this is so that in case there is any other microscopic exposure which has gone undetected, it also gets covered. Now this calcium hydroxide layer is then covered over by a layer of temporary restorative material, which can be zinc oxide eugenol or resin modified glass ionomer cement. The purpose is formation of dentine bridge which would close the exposure. I want you to look at the diagram. Now we want this exposure site to get closed. To achieve this, it is very important that the dentinal tubules in this area plus the area along the excavated dentine right along here, they are properly covered by calcium hydroxide and they get sealed so that there is no entry of bacteria or bacterial toxins. This will promote healing, hence allow dentinal bridge to get formed here. The duration is 3 months, and the outcome is that we periodically check the pulp vitality. If the tooth is vital, no symptoms are present of pain or sensitivity, then the resin modified glass ionomer or the temporary that we have given, it can be replaced by a permanent restoration. Supposing the tooth becomes non-vital along the way, then we should plan root canal treatment. So this was a procedure of direct pulp capping. I hope you followed it. I hope you enjoyed your lecture. Do subscribe to this channel and share it with your friends. Also check out videos on operative hand instruments and class 2 cavity preparation. Thank you.